This conference will now be recorded.
You see, the topic is much relevant in the present era because the prevalence of endometriosis has been increasing. You see, endometriosis is a progressive, ongoing, and long-term gynecological disorder. Actually, it is not a serious or neoplastic or killer disease, but it has several similarities to malignancy like disease progression, then local inversion, and widespread dissemination. Before entering into our topic, I would like to pass through what is endometrium. See, you know, the inner lining of the uterus is called endometrium. As there is no submucous layer, the endometrium is directly opposed to the myometrium or muscular cord. You know, this is the endometrium, then here myometrium. In between the endomyometrial junction, there is no submucous layer. These two layers are separated only by the basal layer of endometrium. You see, endometrium, that I think you know all these things. Endometrium consists of lamina propria or the stroma and the surface epithelium, stroma and the surface epithelium. And it is very, very sensitive to estrogen and progesterone. The surface epithelium is a single layer of ciliated columnar epithelium. But the lamina propria or the stroma contains stromal cells, endometrial glands, blood vessels, and nerves. The glands are simple tubular and lined by mucus secreting epithelium, columnar, non-ciliated columnar epithelium, which penetrates the stroma. There are two kinds of arterial vessels to pass through the myometrium to enter the endometrium, the spiral and basal arteries. Spiral arteries are... Hello?
Hello, sir.
Spiral arteries, clear?
Yes, sir. It's clear.
Spiral arteries are tortuous or winding arteries and then end in capillaries, which supply the middle and superficial portion of the endometrium, the stratum functionale or the functional part of the endometrium, while the basal arteries remain straight and confined to the basal portion of the endometrium, the stratum basale. So, note all these things. It is highly essential for our presentation, you see. See, what is endometriosis? You know, endometriosis is a peculiar disease of women characterized by the presence of endometrial glands and stroma. That is, endometrial glands surrounded by endometrial stroma outside the uterine cavity and musculature and is responsive to hormonal changes. The presence of functional endometrial glands and stroma outside the uterine cavity and musculature and is responsive to hormonal changes. Around 1/3 of cases may be asymptomatic and majority are symptomatic and cause chronic pelvic pain and infertility. Then the endometriosis are classified into different groups on different aspects. Now, commonly, according to the commonly affected sites, the endometriosis are classified into pelvic and extrapelvic. The pelvic sites are pelvic organs and peritoneum, you know, which includes the ovaries, POD, pouch of Douglas, or the posterior cul-de-sac. You know, posterior cul-de-sac. Cul-de-sac is the lowest portion of the peritoneal cavity. Then the peritoneum over the anterior and posterior surface of the uterus, pelvic side walls, tubes, broad and uterosacral ligaments, and also the deposits may be seen on the cervix, vagina, and very rarely vulva. Then the extrapelvic endometriosis. The sites include distal ureters, bladder and kidneys. Then GI tract, gastrointestinal tract, including sigmoid colon, rectum, ileocecal area, appendix, small bowel, cesarean and episiotomy surgical scars, lungs and pleura, and rarely umbilicus and lymph nodes, especially the pelvic lymph nodes. Next, coming to the prevalence. The prevalence of endometriosis has been increasing in the present era. It is predominantly found in 8 to 10% of reproductive age group women, and the peak incidence between the age of 30 to 40. It can also occur in young girls and very rarely perimenopausal age. See, it is extremely uncommon before menarche and after menopause, but it is seen in postmenopause women receiving hormone replacement therapy. In India, now the prevalence is up to 10%. The endometriosis is a hormonally dependent disease. The ectopic or displaced endometrium, ectopic endometrium means displaced. Displaced endometrium is responsive to hormonal changes. It is not clear what initiates endometriosis, but estrogen is required for the further development of endometriosis. Without estrogen, endometriotic implants has no further development. The growth of endometriotic tissue regresses in pregnancy due to high progesterone level, oophorectomy, and following pelvic irradiation. During pregnancy, there is 100 times the rise of estrogen as well as progesterone, but the progesterone is dominated. That is why during pregnancy, it will not cause any harm. Though proliferative changes are seen, secretory changes are very rarely seen. This may be due to absence of steroid receptors in the ectopic endometrial tissue. Then another classification, see endometriosis externa and endometriosis interna or adenomyosis. The endometriosis externa, you see presence of endometrial tissues in sites other than the uterus or other than adenomyosis, which is called endometriosis externa and which is generally referred to as endometriosis. Then endometriosis interna or adenomyosis, it is very important. You see, adenomyosis, generally speaking, presence of endometrial implants, endometrial tissues in the myometrium. But it has its own definition. You can see here endometrium, myometrium, perimetrium. Here you can see the endometrial tissues are entered into the myometrium. Here scattered here and there with the endometriotic tissues. So adenomyosis is defined as the presence of endometrial tissues, including penetrating glands and stroma in the myometrium, at least one low power field, high power field according to some books, but at least one low power field from the endomyometrial junction. From the here, this picture also you can see, this is the endometrial, the uterine cavity. The dark colored is the endometrium. Then this is the myometrium. So this is the cavity, this is endometrium, and this is the myometrium. So it is defined as the presence of endometrial tissues, including penetrating glands and stroma in the myometrium, at least one low power field. Here and there, endometrial glands and stroma are scattered, or 1 to 2.5 millimeter below the basal layer of endometrium. This here 1 millimeter length, here 2.5 millimeter from the basal layer of endometrium, or the deeper than 25% of overall myometrial thickness. Then only we can call it as adenomyosis. Here, this area is scattered with the endometriotic tissue. See, here the continuous and irregular endomyometrial junction and the tangential section appears as adenomyosis, but cannot tell us adenomyosis. See, as such, entering into the myometrium may be a suspected case of endometrial carcinoma. and the confirmation depends on cell changes. So, with the absence of continuity and presence of penetrating glands and stroma, as per the above criteria, is defined as adenomyosis. This area is never says as adenomyosis. You know, the basal layer of endometrium, including glands and stroma, is seen to infiltrate into the myometrium. Then the surrounding tissues undergo hypertrophy and hyperplasia, giving rise to uterine enlargement. Estrogen receptor mutation. Mutation means alteration or change in form in the adenomyomatous area, and gene polymorphism also postulated or proposed by some scientists. Then what are the types of adenomyosis? Adenomyosis is of two types, diffuse and localized. Diffuse adenomyosis involves anterior and posterior walls, uterine walls, and causes uniform uterine enlargement. Usually less than 14 weeks pregnant uterine size. It will not extend beyond 14 weeks pregnant uterine size. The myometrium is thickened and reveal hemorrhagic foci or adenomyosis form. Then another type is localized adenomyosis. Localized adenomyosis is called adenomyoma. Adenomyoma. It grossly resembles with a leiomyoma or fibroids, but it has much difference from fibroids. Fibroids are encapsulated. It has thick shield like coconut shield, but this adenomyoma has no shield or outer covering. Rarely this adenomyoma means localized adenomyoma protrudes into the uterine cavity as submucous adenomyoma or adenomyomatous polyp. Microscopically, we can see islands of endometrial glands and stroma are found in the myometrium. Then one thing, suppose one patient coming to you, her age between 40 and 50, assume, then multipara, then she is presenting with complaints of severe secondary dysmenorrhea and menorrhagia, sometimes chronic pelvic pain also. Then at the first visit itself, clinically you can diagnose as a case of adenomyosis. But usually the age above 40 years and multipara, delivered more than once, and the main symptoms severe dysmenorrhea and menorrhagia. Then on palpation you will get the uterus uniformly enlarged and usually less than 14 week size and just palpable abdominally. Here you can see this is a section of wall of the uterus with adenomyosis, and this structure is leiomyoma or fibroids. Then very important area, what are the risk factors of endometriosis? First, related with the menstrual cycle, you see, it is common in women with greater exposure to menstruation having early menarche and polymenorrhea. See, polymenorrhea means short cycles with a prolonged bleeding or duration of bleeding. Short cycle means less than 27 days interval between cycles, and prolonged duration means more than 7 days of bleeding. See, women with a shorter interval between menses and longer duration of bleeding are more likely to have retrograde menstruation and higher risk of endometriosis. Then delayed childbearing is a higher income group. There is late marriage and delayed childbearing, and therefore higher number of menstrual cycles and greater exposure to menstruation. The higher income group or highly educated patients or subjects, they are postponing the marriage and childbearing. Again, the parity, low parity. See, 50 to 70% of affected women are childless, and many of the others have only 1 or 2 pregnancies. This also subject to the greater number of greater exposure to menstruation. Then the social class or higher social class. There are clear national, cultural, and socio-economic differences in pathology. Anovulation and endometriosis are more common in higher social class in Western whites or Europe or USA, and rarely seen in Negroes and intermediate in Asian women. See, endometriosis is described as a disease of the rich because the frequency of disease is reported 4 times in private hospital. That is why it is considered as disease of the rich. Then genetic factor or the family history. Genetic factors account for about 10% of cases. Increased incidence in first degree relatives, that is mother or sister, are seen around 6 to 7 times. Possibility of multifactorial inheritance. According to Ayurveda, such conditions can occur due to Bija dosha. Bija dosha and Devada, the Nidana of Yoni Rogas in the context. Then it is also commonly seen in women with a lower body mass index. Less than 20 body mass index, less than 20 kilogram per meter square, or lower body mass index. Between 20 and 25 is average or normal BMI. Between 25 to 30, excess weight, and more than 30 is obese. So see, some beautiful ladies or slim ladies more prone to endometriosis. But in case of obese, there is chance of hyperandrogenism, anovulation, oligomenorrhea or amenorrhea, and therefore lower number of menstrual cycles and less exposure to menstruation. You don't go for obese. See, it is the Mullerian anomalies or obstructive Mullerian anomalies common in women with obstructive Mullerian anomalies and outflow tract obstruction. Women with vaginal and or cervical atresia are more likely to have retrograde spill. The incidence is high in retroverted uterus, one condition described in our classics, Andarmukhi Yoni Weber. See, it is experimentally proved that extrauterine endometriosis is often found with retroversion. It has been found that artificially produced retroversion in menstruating animals powers the development of endometriosis. It is experimentally proved. Then the environmental factors. See, environmental factors include, for example, exposure to dioxin. It is a chemical toxicant which enters the body due to exposure of pesticides in the diet. It has effects on genes, reproductive system, and immune system. But dioxin modulates various hormone receptor systems like receptors of estrogen, progesterone, prolactin, or epidermal growth factors, and also shows immune suppressive activities, and is also a potent inhibitor of T lymphocytic function. Then the diagnostic modalities, repeated or incidence is increasing with the increasing use of laparoscopic and other diagnostic modalities like hysterosalpingogram or other diagnostic modalities can spur infection to the peritoneal cavity, or it promotes the incidence of endometriosis. Then the possible or general pathologic mechanism from endometriosis to the pelvic adhesion state. See, once endometrium gets implanted ectopically over the peritoneal surface or elsewhere, it starts proliferating with each menstrual cycle. See, once endometrium gets implanted ectopically over the peritoneal surface or anywhere, it starts proliferating with each menstrual cycle. More and more deposits grow under the estrogenic influence, then they break down and bleed at menstruation. However, there is no outlet for menstrual discharge. Then the blood and debris collects within the tissues to form cysts. With each menstrual cycle, the collection increases in size, but continual absorption of some of the fluid elements causes blood to become dense and dark colored. Even gradually, this process ends up in fibrosis. around such deposit that cause adhesion and distortion of pelvic organs. This is uterus, tubes on each side, then ovary, adherent ovary with the surrounding structures. Then various theories regarding the development of endometriosis. Pathogenesis according to various theories, or there are various theories regarding the development of endometriosis. Although many theories have been proposed regarding the pathophysiology of endometriosis, no single theory can explain the location of development of endometriosis. The different theories includes one, the implantation theory, John Sampson's implantation theory, then coelomic metaplasia or transformation theory, then histogenesis by induction theory, then venous and lymphatic dissemination or metastatic or spread theory, immunological theory, genetic factors, then molecular or hormonal dependent theories. The theories one by one we may study. First, implantation theory. This is the earliest and most widely accepted classic theory of the retroverted spill of endometrial fragments in the menstrual fluids, which is transported through the fallopian tubes into the peritoneal cavity, are responsible for the development of endometriosis. That is, this is the classic theory. Retrograde spill of endometrial fragments in the menstrual blood transported through the fallopian tubes into the peritoneal cavity are responsible for the development of endometriosis. Then the observations in support of Sampson's theory include endometriosis is common in women with obstructive Mullerian anomalies and outflow tract obstruction are more likely to have retrograde menstruation and higher risk of endometriosis. Women with a short and heavy menstrual cycle are also more likely to have retrograde menstruation and higher risk of endometriosis. And the dependent portions of pelvis. You have studied the pelvic and extrapelvic sides, the ovary. Ovarian endometriosis is there, endometriosis in the cul-de-sac, uterosacral ligament, rectovaginal septum, then posterior surface of uterus, etc. See, uh, this scientist opinion also experimentally proved. It has been found that endometrial cells obtained during menses can grow when injected beneath the abdominal skin or into the pelvic cavity of animal. If the menstrual blood is injected beneath the abdominal skin or pelvic cavity of other animals, there is always chance for the development of endometriosis. See one thing, but retrograde menstruation occurs in 80 to 90% of women and is physiological. So, almost 80 to 90% women having retrograde menstruation, but all are not affecting with endometriosis. So, there must be some additional factors. For example, genetic or some other favorable factors that induce the growth of these endometrial cells in the ectopic location in some women, but not in others. So, there may be genetic or immunological factors, some favorable genetic or immunological factors that induce the growth of these endometrial cells in the ectopic location in some women, but not in others. Sampson's theory successfully explains the pelvic endometriosis, but he fails to explain the endometriosis of distant sites like kidneys and lungs. Next theory, Halban's coelomic metaplasia theory. Metaplasia means transformation of one type of tissue into another that you have studied. This theory postulates or claims that the cells of original coelomic membrane undergo metaplasia into endometrial tissue. That is, the serosal layer of all intra-abdominal organs arise from coelomic or mesodermal epithelium, which is considered multipotent. The ovary, the progenitors of endometrium, that is related to the ancestor, and the Mullerian ducts are commonly derived from coelomic epithelium. This theory explains the endometriosis of abdominal viscera, rectovaginal septum, and umbilicus. But what cause What causes this metaplasia are not known. Then next theory, histogenesis by induction, histogenesis or tissue differentiation by induction theory. This theory postulates or claims degenerating menstrual endometrium endogenous factors which induces metaplasia of coelomic endometrium, coelomic epithelium. According to this theory, the endometriotic tissue secretes a protein called adhesion cytokinase, which is capable of inducing endometrial changes in other tissues, that is, transformation of undifferentiated peritoneal cells to endometrial glands and stroma. Actually, this is an extension of coelomic metaplasia theory. But his theory is also supported that in vitro studies have demonstrated that the ovarian surface epithelium having the potency of transformation to form endometriotic lesion in response to estrogen. In response to estrogen, there is chance for transformation of ovarian surface epithelium to endometriotic tissues. Then another very good theory, the venous and lymphatic dissemination or metastatic or spread theory. See, according to this theory, the occurrence of endometriosis of distal organs like vulva, vagina, cervix, then gastrointestinal tract, lungs and pleural cavity, then umbilicus, surgical scars, and lymph nodes, especially the pelvic lymph nodes, is due to embolization of endometriotic tissue via vascular or lymphatic channels dissemination. In supportive evidence, that is, microscopic islands of endometrium are seen in the pelvic lymph nodes in a high proportion of endometriosis cases. So, this is a supportive evidence for this scientist claiming venous and lymphatic dissemination. Then immunological, next theory, immunological factor theory. Immune system may altered in women with endometriosis. Endometriosis can also considered a condition of immunologic tolerance or decreased cellular immunity to endometriotic tissue. This results in a reduced clearance of shed endometrial cells from the peritoneal cavity. See, the immunological changes may also cause an alteration in the function of macrophages, T and B lymphocytes. Next is genetic factor that I have already explained. Genetic factor or familial predisposition to endometriosis accounts for about 10% of patients. This risk of endometriosis is 6 to 7 times higher if first degree relative sister or mother has disease, which is further increased in case of homozygotic twins or identical twins. The disease also tends to be severe and occur an earlier age in women with a history of disease in a first degree relative. Then the molecular defect it is hormonal dependent. Biologically important molecular abnormalities like activation of oncogenic pathways and biosynthetic cascades causing increased production of cytokines, estrogen, and prostaglandin. They contribute to the development of endometriosis. The endometriotic influence is essential to the, you see, estrogenic influence is essential to the development and continual activity of ectopic endometrium. Sometimes the endometrial implants have been shown to express aromatase. Aromatase means the enzymes responsible for conversion of androstenedione to estrone and estrone and of estrone to estradiol. See, the ovary of theca cell, stroma, and granulosa. Theca cells are responsible for the production of androgen, which is converted to estrogen by aromatization by the aromatase enzymes produced by the granulosa cells. Now we are deviating from the main topic. In PCOS patients, there is theca cell hypertrophy and much amount of production of androgens. At the same time, the aromatase enzyme produced by the granulosa cells is inadequate to convert the whole androgen to estrogen. So the estrogen dominated microenvironment of the ovaries are changed to androgen dominated microenvironment in case of PCOS, that is hyperandrogenism. Here also some aromatase enzymes are working which convert the androstenedione to estrone and the estrone to estradiol respectively. In normal endometrium, progesterone antagonizes estrogen effect during luteal phase of the menstrual cycle. Everybody first proliferative phase, then ovulation, and then secretory phase is dominated by progesterone. So, in normal endometrium, progesterone antagonizes or opposes the estrogen effects during luteal phase of the menstrual cycle. But in endometriosis, there is a progesterone resistant state which prevents the weakening process of the estrogen stimulation in these tissues. See, it has been suggested that endometriotic tissue as well as normal endometrium produces prostaglandins. This may adversely affect the ovum pickup or tubal motility, even in the absence of obvious impairment of the adhesions. Next theory, birth defects. The reproductive outflow tract obstruction can predispose to endometriosis. Well, endometriosis is common in women with non-communicating uterine horn, imperforate hymen, and transverse vaginal septa, etc., where the inside the uterus, the endometrial fluid or the menstrual blood becomes stagnant. There is no outlet for the menstrual blood to come outside. Then the environmental factors I have explained. Dioxin is a chemical toxicant which enters the body due to exposure of pesticides in the diet. Then the most modern theory, see, the research have now revealed that several biologically active substances are produced in the ectopic endometrial tissue that are responsible for various stages in the development of endometriosis from implanted endometrium. So several biologically active substances are produced in the ectopic endometrial tissue that are responsible for various stages in the development of endometriosis from implanted endometrium. The biologically active substances produced in ectopic endometrium are one, cytokines. It is responsible for adhesion to the peritoneal surface. Then matrix metalloproteinases responsible for inversion, then vascular endothelial growth factor responsible for angiogenesis or new vessel formation, then growth factor for growth of endometrial tissue, estrogen for proliferative changes, and prostaglandins causing inflammatory reaction. Then immunological and genetic factors also determine the survival of the regurgitated endometrial cells and their addition to peritoneum or peritoneum and its growth. See, what is the mechanism currently proposed or the mechanism of currently proposed pathogenesis of endometriosis. Here, the total coincidence of genetic, immunological, molecular, and mechanical factors, there is implantation of ectopic or displaced endometrial cells and addition to the peritoneal surface under the influence of biologically active cytokines. Then, due to the presence of vascular endothelial growth factor, there is angiogenesis. Again, growth factor promotes the growth of the endometrial tissue. Then, due to estrogenic influence, proliferation is occurring. Proliferation or cell division. The proliferation or cell multiplication is due to estrogenic influence. Then prostaglandins are responsible for inflammatory reaction, and final stage, finally the development of endometriosis is the newer theory. See, our perspective, according to Ayurveda, how the endometriosis is occurring. See, no, 20 or Vimsadi Yoni Rogas and some other gynecological conditions described in our classics, no single disease can explain the condition of endometriosis. Yoni Rogas like Andarmukhi, Udavarta, and Vadagi, again, the Vadaja Granthi are the responsible conditions for the pathophysiology and various stages of the development of endometriosis. See, Andarmukhi Yoni Vyavat, which is closely resembled to retroversion. Due to the involvement of Vada, retroversion favors Vimarga Gavana Srododishti. Adipravartir Sangova, Srodasam Grandhayo Viva, Vimargado Va Gamanam, Srodasam Dishti Lakshanam. Here, due to the involvement of Vada, retroversion favors Vimarga Gamana Srododishti and retrograde menstruation. That is, a regurgitation of the Ubadadu Artava, leading to the condition of Udavarta. Genetic or a genetic factor or Bijadosha, and or it is one of the favorable factors in some women responsible for the development of endometriosis. Due to the association of kapha, adhesion, growth, and proliferation of implants on the peritoneal surface can occur. Then, see, on the basis of clinical features, Vadigi Yoni Roga shows the symptoms of endometriosis like stiffness, roughness, fatigue, lethargy, toda, vedana, stambana, then chronic pelvic pain, or pain over the inguinal area or flanks. Then the old and long-standing lesions have similar lakshanas of Vadaja Granthi with the formation of endometriotic cysts. Then, if not properly treated in the early stage itself, there is angiogenesis and inflammatory reaction due to association of pitta, along with the dhadus, dasa, and rekta. Then, rasa and rekta dhadus favors vascular and lymphatic spread and development of endometriosis in the extrapelvic sites and complicated to the lakshanas of asagdara. The complications of Yoni Roga, Idi Yonigadanari, Yashaklan Pradeshadi, Asagdara, Arsho Gulmadin, Abadamsa, Aniladifi. So, if not properly treated in time, due to the involvement of recta, there is chance for which favors the vascular and lymphatic spread and the development of endometriosis in the extrapelvic sites and complicated to the lakshanas of asargdara or menorrhagia or polymenorrhagia. Then rectal involvement causes painful defecation, stricture, and constipation, asargdara, arsha, gulma, etc. Finally, with the involvement of all the three doshas, the extrapelvic endometriosis can occur in any organ system, that is Abadamsha Aniladvi, but not frequently encountered. Again, due to the involvement of Sukradadu and the Sukravaha Srodha, the ultimate complication, infertility may result. And very rarely malignant changes occur but the prognosis is good. Next, another classification, pathological classification of endometriosis and macroscopic appearance. See, pathologically, endometriosis are classified into three groups: superficial endometriosis, ovarian endometriosis, and deep infiltrating endometriosis. What is superficial endometriosis? The superficial endometriosis is also called peritoneal endometriosis. Lesions are usually seen in the dependent portion of pelvis. Pelvic endometriosis, that is the most common sites are surface of ovaries, only on the surface of ovaries, usually involving both sides, anterior and posterior. Then the pelvic peritoneum over the anterior and posterior surface of the uterus, pouch of Douglas, broad and uterosacral ligaments. Then the deposit also may be seen on the cervix, vagina, and rarely vulva. Then pelvic lymph nodes are also involved in 30% of women. The gross appearance of superficial endometriosis varies depending on whether the lesions are early, old, or long-standing. Early lesions are pink, red, or hemorrhagic and become brown or bluish black. Bluish black appearance is also called powder burn. And puckered, puckered means wrinkled or extensive scarring, ചുളിഞ്ഞു എന്ന് പറയാം, with time. See, or gradually or eventually in old and long-standing lesions, the discoloration disappears and the lesion appears white and fibrotic. The superficial endometriosis cannot be palpated. Palpation, examination by touch. You can't touch or feel. The superficial endometriosis, which cannot be palpated on clinical examination, or they are difficult to visualize on imaging, on ultrasonogram or MRI, and the diagnosis is only by laparoscopy. Then, ovarian endometriosis. See, ovarian endometriosis, they are also called ovarian endometrioma, which is differ from superficial ovarian endometriosis. You see, superficial endometriosis where also ovaries there, where the endometriotic implants are only over the endometrial surface, either anterior or posterior. That is, which is confined to the surface of ovary only. But here, the ovarian endometrioma, one picture is here, how the endometriotic implants entering into the ovaries or in the ovaries. The amoeboid movement, the foot vacuoles of amoeba like inversion and invagination of ovarian cortex with superficial endometriotic deposit is said to cause these deep lesions or cysts. So, inversion and invagination of ovarian cortex with superficial endometriotic deposit causes the deep lesion. Thus, the surface endometrial implants are entering inside the ovary, which gradually enlarge and are filled with old blood. See, the typical features of ovarian endometrioma at laparoscopy or laparotomy, the size of no more than 12 centimeters in diameter, usually adherent to the pelvic side wall, then posterior surface of the broad ligament, posterior surface of uterus. Again, retraction of the ovarian cortex can. The powder burns, that is blue-black spots are seen on the ovaries and is filled with the tarry, thick chocolate-colored fluid. That is why it is called chocolate cyst. This is the picture of section of endometrioma. At the center, here you can see the chocolate type syrup, so it is called chocolate cyst. This here surface is not smooth. Here invagination is also seen again. Then last, deep infiltrating endometriosis. This is also called a posterior pelvic endometriosis. By definition, deep, the lesions extend more and more deeper, or the lesion extends more than 5 millimeters beneath the peritoneum. They are usually located in the especially the rectovaginal space, but may involve the uterosacral ligament, cervix, bowel, or ureters. The lesion causes inflammatory reaction and adhesion formation and can cause malignancy. Here, the lesion can be felt on pelvic or perirectal examination as tender indurations. Indurations or hardening, tender hardening and nodularity or small nodules you can palpate. Then they can be visualized on imaging, but the extent of depth, how much deeper it is, the extent or the depth cannot be assessed at laparoscopy. Then the microscopic appearance of endometriosis. Microscopic appearance or histologic diagnosis of biopsy specimen. Microscopically, endometriotic lesion consists of endometrial glands and stroma and hemocidin-laden macrophages, or the evidence of chronic hemorrhage, are often seen. Glands may reveal proliferative or rarely secretory activities. Deep infiltrating lesions are sometimes surrounded by fibrous and smooth muscle tissues. In women with the endometriosis of long duration, the typical endometrial glands and stroma may not be visualized. Here, how will you here you can see the ovarian stroma, normal ovarian stroma, then presence of endometrial glands and stroma. Here you can see the hemocidin-laden macrophages, as it is an inflammatory condition. Hemocidin-laden macrophages means blood consumed, and enlarged macrophages can be visualized the on microscopic appearance. That is how diagnosis this one. The positive histology confirms the diagnosis, but negative histology does not exclude it. Positive histology means the at least 2 of the 3 following microscopic features should be present. That is endometrial type glands, endometrial type stroma, or evidence of chronic hemorrhage or hemocidin-laden macrophages. So, one thing you remember, the positive histology confirms the diagnosis, but negative histology does not exclude it, because in long-standing lesions, we can't identify the endometriotic type glands or stroma. It is covered with the fibrous tissue. Next, the risk of malignancy. Rarely, very rarely, ovarian clear cell carcinoma and endometrioid carcinoma can develop in endometriosis. Therefore, endometriosis in perimenopausal and postmenopausal age should be excised or removed completely when surgery is undertaken. See, malignancy, since malignancy or malignant transformation seems to be estrogen dependent, estrogen replacement therapy should be administered under supervision in postmenopause women with non-endometriosis. Otherwise, it can change to malignancy. Though endometriosis is no longer considered as a malignant disease, there is very few chance for the possibility of adenocarcinoma or other malignant disease arising in the island of endometriosis. But some studies have said that development of malignant disease are seen in the seen in rectovaginal septum or ovaries or bowel, cervix, and in uterine adenomyosis. The ectopic endometrial implants exhibit cellular proliferation and invasion. 3 factors can be considered, that is angiogenesis, then extracellular matrix remodeling or apoptosis. Angiogenesis means endometrial tissue develops its own vascular supply and become an independent growing mass. So, endometriosis is also considered as angiogenetic disease. Endometrium itself is a rich source of growth factor which promotes angiogenesis like fibroblast and vascular endothelial growth factors. Then what is extracellular matrix remodeling? It has been found that extracellular matrix turnover in patients with endometriosis is altered. A group of enzymes called matrix metalloproteinases, which inhibit or which promote invasiveness of the endometriotic tissue. What is apoptosis that you studied? Several investigations have revealed that the uterine endometrium in mammals can be regulated by apoptosis or programmed cell death. With the normally the addition of endometrial cells or the proliferative cells are inactivated with progesterone, like the uterine endometrium in mammals can be regulated by apoptosis or programmed cell death. It has been found that decreased susceptibility of the endometrial tissue to apoptosis contributes to endometriosis. Then we are going to diagnose? How will you diagnose the endometriosis? See, diagnosis of endometriosis is made on the basis of history, physical findings, and investigation or clinical diagnosis. Endometriosis should be suspected. You should suspect one woman coming with you with complaints of infertility, dysmenorrhea, dyspareunia, cyclic or acyclical chronic pelvic pain. You can definitely suspect it may be a case of endometriosis. But one third of cases may not be or may be asymptomatic, or even with the disease is advanced and accidentally discovered during laparotomy or laparoscopy. Again, on pelvic palpation, adnexal tenderness, adnexal masses, or tenderness and nodularity over the uterosacral ligaments can be suggestive of endometriosis. But a more certain diagnosis, direct visualization of lesions during laparotomy or laparoscopy, but histologic diagnosis of biopsy specimen has been gold standard for diagnosis. But histologic diagnosis is always the gold standard for, or the final diagnosis should be on the basis of biopsy specimen. Then what are the symptoms associated with endometriosis? Pain. There are different kinds of pains that I can explain one by one. Then disorders of menstruation, cyclical bowel bladder symptoms, then general ill health or chronic fatigue and other symptoms, and finally infertility. Pain first. See, dysmenorrhea, dyspareunia, dysphagia, dysuria, dull ache of abdomen. It can be described as described under 5Ds. 5Ds. See, painful menstruation, painful coitus, painful defecation, painful urination, painful ovulation, dull ache of abdomen, and chronic pelvic pain, acyclical pelvic pain are commonly associated with endometriosis. First, what is dysmenorrhea? You have studied dysmenorrhea is of how many types? Two types, primary and secondary. Primary dysmenorrhea occurs a few years after menarche, that is, when ovulatory cycles are established. Usually it occurs below the age of 20. The pain is in case of primary dysmenorrhea, the pain is suprapubic and radiates to the back and thigh, and the associated complaints may be nausea, vomiting, diarrhea, and syncope. See, here in primary dysmenorrhea, the associated symptoms are mainly related to the alimentary system. And additional features means anxiety, stress, etc. And generally, which disappears a few years after or below the age of 20 itself, usually subsides, or especially as after a vaginal delivery. Then secondary dysmenorrhea occurs several years after menarche, means more than 20 years of age, secondary to pelvic pathology, having some additional pathology, so-called secondary to some pelvic pathology or congestive dysmenorrhea. Pain starts 1 to 2 weeks before menstruation. That is, during the secretory phase itself, pain starts and increases with the onset of menstruation. The causes may be endometriosis, adenomyosis, chronic PID, cervical stenosis, fibroid uterus, ovarian mass, Mullerian anomalies, or pelvic congestion syndrome. Pelvic congestion syndrome is had. This is a condition associated with the dilatation of veins, stagnation of stagnation of blood, and reduced clearance, and which give rise to chronic pelvic pain, pressure, heaviness, dyspareunia, etc. And the pain is exaggerated while on prolonged standing. Then here in this condition case, dysmenorrhea associated with the endometriosis. That dysmenorrhea is usually secondary, and the pain starts a few days before the onset of bleeding or during the secretory phase and become progressively worse or severe near and during the menstrual periods and extends for a day or two into the postmenstrual periods. Then what is dyspareunia? One word definition, painful coitus, but it has its own definition. Dyspareunia. What is dyspareunia? Dyspareunia is referred to as pain before, during, or after sexual intercourse. It is traditionally classified into superficial and deep dyspareunia, pain that occurs at the introitus during insertion of penis in or in the mid vagina is superficial dyspareunia. This occurs due to painful lesions in the vulva or vagina. Causes may be vaginitis, vulvar skin lesions, vulvodynia. Vulvodynia means chronic pain and discomfort around the vulva or the entire external genitalia. No identifiable cause. Usually last for more than 3 months and which results the sexual dysfunction. Then vulvar vestibulitis, then prior episiotomy or other surgeries, postmenopausal estrogen deficiencies, then vaginismus. Vaginismus means maybe due to spasm of perineal muscles and levator. This can also considered under superficial dyspareunia. The condition may be psychogenic and may be related to sexual abuse or lack of sexual interest or tight introitus. These are the something related with the superficial dyspareunia. Deep dyspareunia is due to the painful lesions in the pouch of Douglas or uterosacral ligaments. Uterosacral ligament is the main ligament which keep the uterus in underverted position. So uterosacral attachment from the posterior surface of uterus to the sacrum. So deep dyspareunia is due to painful lesions in the pouch of Douglas or uterosacral ligaments and is experienced during deep penetration. Causes may be endometriosis, chronic PID, anteriorly or acutely retroverted uterus, then adnexal pathology, ovaries collapsed in the POD, etc. In endometriosis, the dyspareunia is usually deep in pelvis. It is usually due to direct pressure or direct contact tenderness on the pouch of Douglas or the stretching of uterosacral ligament. Then involvement of endometriotic implants in the POD and uterosacral ligaments may produce nodular thickening and also shortening of uterosacral ligament. Shortening of uterosacral ligament results retroversion of uterus. Previously, suppose one lady having underverted uterus, after suffering prolonged endometriotic problems, her uterus may turn to retroverted due to the shortening of uterosacral ligament due to the involvement of endometriotic implants on these ligaments. Then what is dysphagia? Dysphagia means painful defecation, irritation, diarrhea, bleeding, meline, means a discharge of tarry or bloody stool are caused by direct involvement of rectum or a rectal stricture can also cause constipation or the condition may stimulate rectal carcinoma, etc. Then what is dysuria? Dysuria or painful urination. Frequency, pain, and cyclical hematuria or hematuria. Cyclical hematuria. During bleeding phase, hematuria can occur due to bladder involvement. You see, frequency means occurring at short intervals. Frequency of urine occurring at short intervals. Urgency means urgent need, etc. Then what are the causes of pain? Causes of pain in endometriosis. Several theories are forwarded. The peritoneal inflammation, then activation of nociceptors or pain receptors, nerve irritation with deep infiltration, then tissue damage, local production of prostaglandins, adhesion formation, collection of blood in endometriotic implants. See, what is pain? According to International Association for Study of Pain, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. See, whether tissue damage or having the potency of tissue damage, then only pain occur. The fresh tissue damage causes acute pain and chronic pain continues long after the tissue injury heals. Pain perception involves the peripheral and central nervous system and is influenced by other social, psychological, or environmental factors. Various modulators like prostaglandin, vasoactive peptides, and endorphin also play a role. That is, the prostaglandin is one of the main factors responsible for modulating this pain. Then next is disorders of menstruation. Menorrhagia. Menorrhagia means excess bleeding either by increasing quantity or increasing duration. It's menorrhagia and premenstrual spotting are usually due to association of anovulation, abnormal follicular development, and pelvic congestion. Intermenstrual bleeding is also reported in some cases. It may be due to cervical and vaginal lesions. Then cyclical bowel bladder symptoms. This pain on defecation and urination, bleeding per rectum and urethra may be experienced cyclically. The cyclical hematuria is more common, but cyclical bleeding from the rectum is less common. Again, the general ill health or general ill health, pulmonary symptoms like cyclic hemoptysis. The patient experience hemoptysis or hemoptysis during menstrual bleeding phase. Then premenstrual symptoms like abdominal bloating, mastalgia, headache, vomiting, mood swings, depression, etc. can occur. Then intermittent pyrexia, especially during menstruation, is present approximately 10% of cases due to absorption of degenerated products of retained blood. Then our main area, infertility. How endometriosis causing infertility. See, whether endometriosis causes infertility or vice versa is not clear. The prevalence of endometriosis is 30 to 45% in infertile women, but endometriosis occurs 8 to 10% in general population, but the prevalence of endometriosis is 30 to 45% in infertile women. There are several mechanisms by which the endometriosis leads to infertility. Causes of infertility in endometriosis, one by one. See, ovulatory dysfunction, where one abnormal folliculogenesis, that is inadequate or disproportionate development of follicles or anovulation. Again, luteal phase defect. Luteal phase defect means inadequate progesterone support or inadequate progesterone production during post-ovulatory phase may result in fertility or early pregnancy loss. Again, luteinized unruptured follicular syndrome. Dominant follicle undergo luteinization without a rupture and release of ovum. So pregnancy cannot occur, but progesterone production occurs. This condition is very rare and seen in some women with endometriosis. See, normally ovulation occurs when the follicular size between 18 to 22 millimeter. Sometimes it grows further and further up to 28 or 30 millimeter and will not burst. No ovulation occurs. That is a hypermaturity of the follicle. Such cases, modern doctors are advising HCG, additional HCG injection, that is human chorionic gonadotropin injection, 5,000 unit or 10,000 unit or the like. But you can address such conditions. Our Leshinakshira or Giragarishta are the drug of choice for the rupture of follicles or in case of luteinized unruptured follicular syndrome. Then again, immunological alterations. There is decreased sperm survival or altered immunity or increased or decreased secretion of various cytokines that regulate the immunological process have been found. Again, peritoneal factor, it is important. Peritoneal inflammation and the local production of prostaglandin or cytokines. See, in case of endometriosis or women with endometriosis, there may be increased peritoneal fluid volume, increased peritoneal fluid WBC, then increased production of inflammatory cytokines, growth factors, and angiogenesis promoting factors. It can identify, or it has been found that there is an increase in number of leukocytes or WBC in infertile women with endometriosis as compared to fertile women. So, infertile women with endometriosis, uh, if you advise on blood sample or routine examination, the total count will be always high in case of women with endometriosis as compared to fertile women. Then gain the interference with implantation, that is endometriotic due to endometriotic dysfunction or maybe due to inadequate secretory changes. Again, some mechanical factors like anatomical obstruction of tubes, interference with ovum pickup, altered tubal motility, peritoneal adhesions. It has been found that endometriotic tissue as well as normal endometrium produces prostaglandins, which may adversely affect the ovum pickup or tubal motility. Interference with coital function. There is dyspareunia may interfere with coital function. Again, sperm inactivation, enhanced phagocytosis by macrophages and natural killer cells or NK cells, which may sperm, engulf sperm or ovum. Then inactivation by antibodies. It has been suggested that the endometriotic implants may secrete substances that interfere with normal sperm motility and thereby impair the process of fertilization. The anti-sperm antibody is a different topic, not related with the endometriosis. The anti-sperm antibodies are present in semen, cervical mucus, serum, ovarian follicular fluid, etc. They may be IgG, IgM, or IgA. They affect the semen quality, interference with the sperm capacitation, motility, fertilization, etc., which is not related with the endometriosis. That is anti-sperm antibodies. Then next symptom is chronic pelvic pain. What is chronic pelvic pain? We have discussed about cyclical pain. Here, chronic pelvic pain is defined as non-cyclical pain of at least 6 months duration, unrelated to menstruation, intercourse, or pregnancy. The prevalence of CPP, chronic pelvic pain, is 15 to 20%. CPP is most common in women in the reproductive age group, especially between 26 to 30 years, but can occur from as early as 18 to 50 years. But the prominent endometrial the prevalence of endometriosis is predominantly seen between 30 to 40 years. But here also, CPP also can occur as early as 18 to 50 years. Pain may arise from pelvic organs. Or refer to the pelvic area. Pain should involve the pelvis, abdominal wall at or below the umbilicus, lower back, and or buttocks. The CPP is unrelated to menstrual cycle, but dysmenorrhea is related to menstrual cycle. CPP may be caused by gynecological, urological, gastrointestinal, or musculoskeletal, or neurological, or psychosomatic conditions. So many conditions can cause this CPP, but in endometriosis also you can see the chronic pelvic pain. The gynecological conditions causing CPP are endometriosis, chronic PID, pelvic adhesions, adenomyosis, etc. Next is the clinical diagnosis. Physical findings. The abdominal examination mass or per-abdominal examination mass arising from the pelvis you can see. Then located in the iliac fossa. Mass may be tender and not freely mobile. Then vaginal lesions may be seen as bluish spots or nodules in the posterior one speculum examination. Then the pelvic examination then may reveal the pelvic mass, fixed retroverted uterus, unilateral or bilateral admixal masses, tenderness, and or tender nodule in the pouch of Douglas. Again, rectal examination is required. If rectal symptoms are present, then you will get the tenderness in the pouch of Douglas or tender nodules in the pouch of Douglas. Again, the next area is imaging imaging ultrasonogram and MRI. Imaging is of limited value in the diagnosis of endometriosis, except in ovarian endometrioma. Ovarian endometrioma more than 2 centimeter size can diagnosed on transvaginal ultrasonogram and appears as cystic mass with a low level internal echo with or without internal septation or partitions. Uh, uh, on ultrasonogram, we will get the result, the septations or hyperechoic and septated or the like. Then MRI or magnetic resonance imaging can identify the lesions more than 1 centimeter, but ultrasonogram identify lesions more than 2 centimeter. Then MRI, it is also not useful for the diagnosis of superficial endometriosis and is less accurate in determining deep infiltrating endometriosis, but is useful in ovarian endometrioma more than 1 centimeter, rectovaginal nodules, and also for evaluation of extensive endometriosis. Another diagnostic factor is CA125. See, tumor markers like CA125, alpha fetoprotein, lactic dehydrogenase are useful in the diagnosis of malignant ovarian tumors. CA125 is a tumor marker for epithelial ovarian cancer. Epithelial ovarian cancer. The levels are elevated in endometriosis but vary widely. So, therefore, it is not a diagnostic tool for the diagnosis of endometriosis, but may be used to detect recurrence. The level of 35 units per ml is used as cutoff value for the diagnosis of malignancy. But this marker, CA125, is elevated in several benign gynecological conditions like endometriosis, PID, abdominal or genital tuberculosis, leiomyoma or fibroid and pregnancy. Since all these conditions are encountered in premenopausal women, the test is not as useful in postmenopausal women. So a cutoff value of 200 unit per ml or cutoff value of 200 unit per ml is therefore used in premenopausal women for the diagnosis of malignancy, not above the level of 35. But you should any patients coming to you and giving during premenopausal or active reproductive period and showing the result of CA125, madam or sir, this is 50 unit per ml. This is too much. May I suffering from some malignancies? No, you can frankly answer. According as far as your age or your reproductive age is concerned, 200 or more. If it is 200 or more, you can suspect malignancy only. Then, what is the role of laparoscopy? The visual inspection of pelvis at laparoscopy can be made a more certain diagnosis for endometriosis. The pelvic structures should be grasped and mobilized, and location and extent of all lesions and adhesions are noted in laparoscopic surgery. Laparoscopy is useful for the diagnosis, again obtaining samples for histology and also for therapy. Then staging of endometriosis. Staging is not so simple. Staging of endometriosis is by the revised American Fertility Society or American Society for Reproductive Medicine, ASRM. Points are allocated for endometriotic lesions, peri-ovarian adhesion, or pouch of the glass obliteration. I'm not going to detail for this classification. Anyway, you should remember that stage 1 is minimal, stage 2 is mild, and stage 3 moderate, and stage 4 is severe. Then the management of endometriosis, medical management. See, there is no permanent cure for endometriosis. You should remember. The best available management is bilateral oophorectomy according to modern science. This is not acceptable in young infertile women. Other short-term goals of treatment are relief of pain and improve fertility. Long-term objectives are prevention of disease progression and recurrence after therapy. This is the long-term objective. Again, the modern medical management, according to the management may be medical or surgical. Medical or surgical. Medical management is by progestrogens, combined oral contraceptives, GnRH, etc. Then the most recent medical management principle we have studied, there are several options for medical management in modern medical science, but the new drugs in endometriosis constitutes selective progesterone receptor modulators. Selective progesterone receptor modulators, that is to regulate by selective progesterone receptors. Then GnRH antagonist. Antagonist means opposing to GnRH. Again, aromatase inhibitors. Aromatization can promote endometriosis. That is conversion of some androgenic tissues to estrone, then estrone to estradiol. So, aromatase inhibitors helps the spread of disease. Then tumor necrosis factor inhibitors, angiogenesis inhibitors. Angiogenesis, when new vessel formation is very high in case of endometriosis. Then matrix metalloproteinases inhibitors, immunomodulators, then beta estrogen receptor antagonists, then selective estrogen receptors modulators, or soften the receptors. Whole destruction of estrogen receptors is not good. Then surgical management. Surgery is indicated in women where medical management is not effective for improving fertility. The surgery may be conservative where uterus and ovaries are preserved, or radical where hysterectomy and bilateral salpingo-oophorectomy is performed. Surgery can be laparoscopic or open. Surgery in endometriosis, the conservative surgery includes cauterization of lesions, laser vaporization of lesions, laparoscopic uterosacral. Only you should look this. Laparoscopic uterosacral nerve ablation, adhesive lysis, cyst aspiration and irrigation, cystectomy, then vaporization of inner cyst wall, excision of rectovaginal nodules, etc. are the conservative modern treatment. Only the 9. Okay. Then radical surgery means the permanent cure, hysterectomy with bilateral salpingo-oophorectomy, with or without bowel resection, ureteric resection, and anastomosis or reimplantation. Then infertility in women with endometriosis may be required assisted reproductive techniques like IVF, TXC, etc. Coming to our science, what is the prognosis? What is sadhya asadhyatva according to Ayurveda? See, involvement of all the 3 doshas and considering the involvement of all the 3 doshas, progressive, ongoing, long-standing nature and complications, the prognosis becomes kritra sadhya, yapya, or asadhya. Long-term oral route administration of Ayurvedic medications are effective in both pelvic as well as extrapelvic endometriosis. Again, anal route administration, that is general route administration, and vaginal, this is topical routes administration of selective Ayurvedic formulations are more effective and useful in rectovaginal endometriosis, superficial endometriosis, and recurrent endometriosis after surgery. There may be significant release of pain, especially dysmenorrhea and dyspareunia. The drug of choice for Snehapana includes Carpasa Taila. WHO accepted the cottonseed oil for endometriosis, then Mahanarayana Taila, Shatapushpa Taila, Kannandaran Taila, then Gulgula Tikta Krida. Since inflammation plays a major role in the pathogenesis of endometriosis, anti-inflammatory conditions or anti-inflammatory, again, we can consider the Vadashonida as one of the conditions of inflammatory disease condition. Then anti-inflammatory combinations described in Vadashonida. For example, the Gulgulu Tikta Krida is highly effective. Again, Mahadikta Krida, Varanadik Krida. Then medicine for Shodhana, for Virejana, Gandharvasta Eranda, Hingatrigana Taila. That is, Vada Samana Virejana is good for the treatment of endometriosis. For Asthavana, Anivasana, then Uttaravasti, Karpasyastedi Taila, Dhanandaran Taila, then Phalasarpis, then Gulgulutikta Krida, etc. can be used. Then Trayandyadi Kashaya, Jivandyadi Kashaya, Nimbadi Kashaya, Bela Kshira Kashaya, Sadavushpa Kashaya, Indiganta Krida, Gulguli Tikta Krida, then Tikta Krida, Sadaviryadi Krida, Kshira Bela, then Dhanandaram Guliga, Gulgulu Panchavara Churna, etc. See, here as far as the treatment of Ayurvedic system is concerned, the Uttaravasti plays a major role. I mean, here the vaginal route administration has been proved to be superior to oral route administration because vaginal route has many advantages due to its large permeation area, then rich vascularization, avoidance of first metabolic or hepatic pass effect, relatively low enzymatic activity, then suitable site for bioadhesive formulations, etc. Large permeation, vaginal rugae and ridges on the epithelial surface allow the stretching of vagina and increase the absorbed area, which enhances the retention and absorption of formulations. Then vaginal permeation of drugs across vaginal epithelium may be paracellular or adjacent epithelial cells or transcellular. You have studied the hydrophilic or water-soluble easy ionization. Then hydrophilic compounds prefer paracellular route, and with the molecular size being inversely related to the absorption rate, means the smallest particle size reach the site easily when comparing with the large particle size. Similarly, passive diffusion through tissues. Ghee or oil preparations for pane vastoja chickanapaga preparations are lipophilic in nature. The viscosity, pH, particle size, and dissolution rate are suitable for mucosal absorption, which diffuses freely into cells where it binds to the concerned progesterone or estrogen receptors and exerts desired activity. The steroid receptor complex bind to DNA in the nucleus, thereby inducing the synthesis of specific proteins. See, here some pathya and abhathyas are also advised. You should strictly advise the patient to avoid masha, tila, soya, surana, kumari, broiler chicken, etc. These having phytoestrogenic effect that can enhance or promote the development of endometriotic implants. Then you can advise Bela, supposed to have progesterone-like action. Kshira Bela also has progesterone-like action. Khadira supposed to have androgenic action. Estrogenic influence can be inactivated with androgen also. The Gokshira also supposed to have androgenic effect. Then Amalagi, very good antioxidant. Malsya, you can simply advise. Then curcumin. It is also better for the patients having or women with endometriosis. See, evaluation and management of endometriosis should be directed towards prevention or at least limiting adverse outcome. Successful spontaneous pregnancies occur in minimal and mild endometriosis after Ayurvedic medical treatment. Thank you, one and all. Hello.
Thank you so much, sir, for such an amazing class. We should wait for the queries.
Yes. Ask some questions, please.
You can ask the queries in the chat box. We shall discuss them soon. Sir, there is one query regarding the use of Lashana Shira Pagam. Could you repeat the context and explain why?
Yes. In luteinized unruptured follicle syndrome, you can advise Lashana Shira. Lashana Shira take the Lashana 20 or 25 leaves of Lashana, not the 25 Lashana as such, but 20 or 25 leaves of Lashana. Then put it in 1 glass of milk. Then add 2 more glasses of water. Then reduce to milk amount or reduce it to 1 glass, and advise the patient to take in a single dose. From suppose one typical cycle means 28-day cycle patients having the ovulation at the 14th day of menstruation. That is, ovulation usually occurs 14 days prior to the onset of coming bleeding phase. So, in a typical once in 28-day cycle subjects, the ovulation you can anticipate on the 14th day of LMP. So, around 5 days prior, you can start the Lashana Kshira. That is, from 9th, 10th, 11th, late proliferative phase itself, you can start. That is 9th, 10th, 11th, 12th, or 13th day. Or you can advise one more day, up to 14th day of LMB, this Lashana Kshira, 1 glass prepared Lashana Kshira as 1 dose. Definitely, it will help to rupture the follicle or the hypermaturity of the luteal due to luteal phase defect. Similarly, Jeeraga arista is also somewhat good for rupturing this follicle after attaining between 18 to 22 millimeter size diameter. Okay. Hello.
Yes, sir. Thank you so much. So the next question is, Shira is advised as a patya, but Shira is often contraindicated in case of inflammatory disorders. So in what form can we advise, or in which stage is it advisable?
Okay. Kshira, milk, which thing? Please ask, bring once more.
Sir, Shira is advised as a patyahara, yes, sir. But usually in inflammatory disorders, it is contraindicated in the initial stages. So how exactly or in what form can Shira be advised?
No. Kshira is not contraindicated, or it is not advised contraindicated anywhere. Kshira is supposed to have androgenic, or it has androgen like effect on the, it is alkaline also. So it will definitely inactivate androgen with androgen. That is, danazole preparations modern doctors are giving for the control of endometriosis. Like you can definitely advise. Narim Thailand Marsha Pitale Samubajare, but Naram Vishesha Shiraji. So androgenic influence, those drugs or combinations having androgen like action, definitely you can advise this one. Lashana Kshira, see, unruptured follicular syndrome is very rare and is seen in some endometriotic patients. So, Leshina is, the quality of Leshina or the properties of Leshina, Leshina of Frishas Tishnoshna or the excess Tishnatva can inactivate with milk. So, you can definitely advise without any hesitation to advise the patient only for a rupturing of this unruptured follicle in case of unruptured follicle syndrome. So, milk is padhya. I think anywhere it is prevented to take.
Thank you, sir. Hope the doubt was cleared. Any other queries are welcome. Kindly post them in the chat box or send us personal messages.
Ask some more questions, please. Yes. Can Chandraprabha Guliga be given throughout the cycle in patients having infertility associated with endometriosis? No. Chandraprabha tablets can alter the electrolytic balance. Means there may be a loss of or the sodium potassium balance. So Chandraprabha Guliga, you should advise a limited period only. Otherwise, it will definitely alter the patient's electrolytic balance, and there may be patients feel the potassium sodium imbalance. So, up to a limited period, you can see modern doctors are advising antibiotics for 3 days, 5 days, 7 days, or the like. You can advise Chandraprabha for limited days, but you can advise Punarnava Gulgulu tablet for prolonged use. It has anti-inflammatory effect. Is Nasya beneficial in endometriosis? In endometriosis, therefore, as considering, because I think it has not so much role. Nasya has not so much role in curing endometriosis. Nasya, suppose one anti-estrogenic preparation like Kalyana Krida, if you are adding to nasal cavity or administrating Nasya, it will reduce the concentration of estrogen. Then after the stoppage of Nasya procedure, there is sudden acceleration of GnRH and anterior pituitary FSH, etc. Then it may, I think, adversely affect. There is chance for excess production of or high level production of estrogen can occur. So Nasya is not good, but at the same time, Nasya is contraindicated during those who are in the during or just prior to ovulation. Not Ksharagritya Irdumadi or Nasya and Kshara, administration of Nasya and Kshara are contraindicated in women with normal women or women with other ailments during or just before and during menstrual periods. It can reduce or it will pacify or it will reduce the estrogenic influence, but we have to maintain the fertility potential of female or lady, as well as we have to pacify the endometriotic adverse effects. According to modern medical science, all the medicines are in effect contraceptive, but our medicines, our treatment, during the treatment period itself, patients can conceive. So we have to maintain the normal estrogenic level as well as normal progesteronic level. Then we have to retain the ovulation, etc. Then only conception can occur. Those who have completed her family, the continual administration of Nasya or Chara is possible. But Chara, it is an ovariotoxic. So during the active reproductive period, you don't advise Chara. Or those who have not completed their family, you don't advise Chara. Chara is ovariotoxic. But you can advise the patient after 40 years or 45 years for endometriosis or adenomyosis or fibroid uterus or any hyperestrogenic state diseases. Next one, can you throw some light on Shibaguliga with the endometriosis? I am not using Shibaguliga, but Shibaguliga can be used. Instead of Shibaguliga, Jeevandyadi Kashaya we are advising, it will maintain the immunity, or in order to activate the immunity of the patient or the subject or the woman with endometriosis, you can advise Shibaguliga. Shibaguliga also have androgen-like action. It is doctors usually advising Shivaguliga for male infertility also. What are the medicines for male infertility, or what are the medicines having progesterone-like action? You can advise for endometriosis also for inactivating the hyperestrogenism of that particular condition. Next question, can you advise some medications for improving ovarian pickup and tubal motility? Tubal motility, normal estrogen provides the uterine contractile action, but normal progesterone provides uterine as well as tubal relaxant effect, but estrogen is needed for uterine contraction. But endometriosis is a hyperestrogenic state and a pathological state. That is why ovum pickup is not possible, the like ectopic syndrome or the like. But in order to get proper ovum pickup, you can advise Sukumara Hrida. Sukumara Hrida for normal patients, not those who are suffering from endometriosis. Sukumara Hrida can activate or enhance the disease or can promote the progress of the disease. Or otherwise, in other patients or those who are not suffering from hyperestrogenic states, or normal patients or normal subjects suffering from ovarian or ovum pickup or reduced ovum pickup action or ectopic syndrome, then you can advise Sukumara Hrida. Sukumara Hrida is supposed to have estrogen-like action. Estrogen is responsible for the contraction of the tube, but progesterone having uterine relaxant effect. That is why if you are advising any medicine having progesterone-like action, only after the 4th day of fertilization. Otherwise, there is chance for decidua means pregnant uterus is called decidua. Early decidualization in the tube itself, that may cause tubal pregnancy or ectopic pregnancy. So you should maintain the uterine or the tubal contractile state or tubal rigid state or tubal motility and or mobility state till entering the fertilized ovum to the peritoneal, endometrial cavity, or wait for 4 days. 4th or 3rd or 4th day, the fertilized ovum or the morula reaching into the uterine cavity. Up to that period, wait for maintain the estrogenic influence. So you can promote or you will get ovum pickup action in patients other than endometriotic patients with substances or combinations having estrogen-like action. Best choice is Sukumara Hrida. Ask some more. Hello, nothing to ask. Yes. If the symptoms are subside, if there is need of continuation of medicine for endometriosis in next cycle. See, I will bring you one combination. You can advise here it is secondary dysmenorrhea. It starts from the secretory phase onwards. So you can advise 1 week prior to the bleeding phase with this medicine, and you can stop the medicines in order to prevent dysmenorrhea. Best choice or best combination is Saptasaram Kashaya with Kingutrigana Taila or Sugumara Eranda. 10 ml Sugumara Eranda and Saptasaram Kashaya. You can advise from suppose one typical menstrual cycle 28-day patients from the pain usually occurs at the 14th day in typical 28-day cycle patients. You can advise this combination 1 week prior to the from the anticipated ovulation day and continue 2 more days. Was total 7 or 9 days enough for this patient. Then you should advise prolonged treatment for the basic curing of endometriosis with so many drug of choice I have showed. Like Mahanarayana Taila, Dhanandaran Taila, Gulgula Chittakrita, Gulgula Panchabala Churna, or anything, you can advise in between the periods or in between the dysmenorrhea periods for permanent cure. Then the severity of, if the severity of endometriosis subsides, the pain also simultaneously subsides. Then in order to manage the severity of dysmenorrhea, advise the Saptasaram Kashaya with the Kingutrigana 10 ml is enough. Then, sir, Saptasaram indicated in endometriosis. Yes. What may be the Virya? Is Saptasaram Kashaya, I think my concept is it has some mechanical role. It will reduce the prostaglandin effect, or it will reduce the excess contraction of the unusual contraction of the uterus, contraction of the body, and stiffness or rigidness of the cervix, the pain occur due to. So, in administration of Saptasara Kashaya has some mechanical role. It will definitely dilate the cervical passage, and also it helps to reduce the hyperprostaglandin stimulation. Then it also bring the non-contractile state of the uterus. It has more mechanical or prostaglandin subsiding effect, but it has less biochemical role.
Thank you, sir. If there
Yes.
are any more queries, we can wait for a while more.
Yes. Yes.
Hope the queries are clear. I now call upon
Yes.
Arundhati.
Yes.
Good evening to one and all present here. It is such an honor for me to have an opportunity to thank you all dignitaries on behalf of House HSA 2122. I would like to express my gratitude to all esteemed delegates for their presence and contribution to make this webinar a great success. I extend my gratitude to our Honorable Sir Dr.N Vijayakumar for taking time from his busy schedule to grace the event. Thank you, sir, for inspiring and encouraging us with your extensive knowledge. A special thanks to Dr. Jay, Principal of Government Ayurveda College, Trivandrum, for providing immense support to make the webinar happen. I must thank the organizing team of VEEKSHA Academic Series for the sincere effort in conducting a series that will deepen our clinical knowledge. Thanking all the attendees of the meeting for their active participation. Once again, thank you everyone for making our 8th session of VEEKSHA Academic Series a fruitful one. Thank you.
Okay.
Thank you once again, sir, for the sincere class, and to everybody for the active discussion and the patient listening. Do follow our FB and Instagram pages for updates on upcoming webinars. Thank you, sir. Thank you, everyone.
Once again, I would like to express my sincere thanks to one and all, especially Arindhati and all other organizers and the association, House Savings Association. Okay.
Thank you, sir. Thank you so much. It's a pleasure.
Okay. Bye.